Well, thank you for that introduction, and that I think that says most things you need to know about me in terms of this presentation. As you can see from the title, I'm going to talk about what it's entitled The Generation of Practitioners, and it'll have a focus on workplace learning and the practical aspects of that, as opposed to a broader conceptual framework that Joy offer. And I think it is important to stress that I do work on both sides of the divide. And sometimes when I sit in a hospital, it can feel like I'm sitting with a great Grand Canyon even between my other office. So, because there are cultures that are different as all those other cultures I've listed there. And I feel that I experience the reality of that frequently. So this presentation, as I said, will focus on workplace learning and supervisory practice. Now I want to draw on a recent study in medicine, but for those of you that aren't in medicine, I do believe it applies to any professional body, particularly any professional body with strong occupational standards. And discuss some work that we did with junior doctors about what they learnt in the workplace, and discuss the implications for supervisors. And then I have some questions to raise about practice-based education and curriculum design. So, with the people that I work with, the junior doctors doing their last year before they can be registered. So it's totally practice-based education and workplace learning. And it's certainly a really tough year, and all of those of you who work in a profession where you have a first year of practice, it's a really tough year, there's no doubt about that. But as they would say to me, you learn a lot. And that seems to be important. So, how does this happen? How do they learn a lot, and what makes them practitioners? Because by the time they finish their first year of us, if they're not practitioners, they stay around being a no man's land, because we don't always pass them. And so what makes a practitioner, how they develop, and how can the workplace supervisor help make that happen? They are questions that are of real interest to me. And I was working with a couple of colleagues, Tim Wilkinson's colleague who's medical education curriculum, some of you might have read his work. Elizabeth Bowie was one of our house officers, and she'd just completed 2 years. And we wanted to know what they actually learnt first, because we realised we didn't really know what they learnt. We knew they were assessed, or yes, but actually what had they learnt, which we suspected were two different things, unfortunately. I see David looking at me as if to say, yes, well, that shouldn't have happened, but I think that's what happens. So, what do newly qualified doctors really learn in practice? That was our inquiry question, and I won't describe, and can ask me later about how we designed the program, but it was joint inquiry with the junior doctors themselves across a couple of locations, one regional, 2 metropolitan hospitals, and essentially qualitative interviewing, but with a lot of involvement from the doctors themselves. They're intelligent, clever people. They can tell you a lot in a group as well as individually. And we asked them these kinds of questions. I'm not going to read them all, but we just asked them general questions to try and tap into their tacit knowledge about what they learnt, because of course this wasn't obvious to them. So we had to be quite cunning and talk around the subject in many ways. And after we'd done that and we were collating the information and we debated what the themes were, you know what that feels like. You have collections of stuff, and what label do you put on it? Really interesting process. But we decided they were these 3 things, and this is all pretty obvious to those of us who are interested in practice, particularly the first one. And by concrete tasks, I also mean clinical decision making, or those clinical tasks that people do. And we actually weren't that interested in that, because that's what we assessed. We knew they learnt that, because that was what we assessed. And we were interested in the other 2. And one we labelled project management. That might be contestable, but I'm going to talk about both of these, because they're much more interesting. So project management. Project medicine is about the paperwork. It's about keeping the show on the road. This is their terms. It's about getting things ready for ward rounds. It's about discharge planning, it's about team liaison, it's about all these things that are just about doing the job. And when you're experienced, they are just doing the job. Junior doctors hate this. And it's really complex. And we don't need to follow this diagram, But if you were teaching project management, this is what one of those fancy charts they teach you. No, but no one teaches the junior doctors these fancy charts. But actually, this is what they have to be able to do. And those things are very complex. All of them are very complex. This is the type of things the engineers do, you know, after they've been practicing for 5 years. So, there are clear implications for that for practice-based education. Because it certainly made my medical colleagues think, oh, do we teach anything about this in the undergraduate curriculum? And amazingly, they don't teach project management, but project management is the main job of a junior doctor. And so there's important implications for their preparation for practice when they arrive with us, important implications for orientation, which is one of my responsibilities, so I take this coordination more seriously now, how to fill in the forms, how to do the paperwork in this place. And there are really big implications for their support. Because one of the most common reasons for one of our junior doctors having to maybe spend an extra 3 months before they're registered is what we would call time management. And now think about it as project management. Of course they can manage their time. They get there on time. They can get to parties on time. They can get to lunch on time. They can leave work on time. They're very thorough about that. But they can't always organise the patient flow. There are other reasons that they can't do that. It's not time management. They have superb time management skills. So that's one of the things that's interesting, and we've started to take more notice of it. This one is the one that really fascinates me at the moment, which is identity formation. And that was these things that I've listed here, about becoming an employee, making mistakes, having arguments with nurses, being bullied by nurses, they would say. And we see that as about dealing, though, with aligning how they see themselves with the professional expectations around them. And that'll be no surprise for people here. This is some of the things they said. I mean, it's quite sad, really. At med school, you seem to think you can deal with anything. But then once you started work, you realise so much is out of your hand. Getting thrown in, bluffing what you know. And when I read that, and one of the house officers that I know said that, I think, don't you know we all bluff it all the time? It's always, it's part of life and health. But this is some of their quotes and the way they feel about that period of time. But this section are interesting too, because they're about the difficulties with other staff. They talk about the difficulty with nurses the most. But that's really interesting, and it's very, very real for them. We have a lot of tears around us. So the question that then came for us is this a conflict, or is it something else? Is there another lens we can use to look at that? And when I was thinking about that, I came across the work of somebody called Les Holmes, and I really like this model. It comes from management. Has anyone seen it? Yeah. I find it really useful, because what he's talking about here is how people move to being here. So the goal when you're a newbie, it's one of those boards that does that. The goal when you're a newbie is that you start here and you move over there. And for Holmes, this is a newbie anywhere. Could be one of us going to do something new. But for my junior doctors, they come in here, they think they're a doctor, because they just finished their study, and they have no idea. And they really have no idea. It's very frightening if you're a patient. They come in here, and then they sort of put in here, and life's really difficult when you're in here. Because now and again, you do something, and you put yourself out there, and you're kind of saying, this is part of my job, I'm doing it, and someone goes, no, you're not, usually the charge nurse, or your registrar, no, that's not something you do. We don't trust you to do that. Sometimes people come and say to them, will you do so-and-so? The classic in my environment is, consent this patient for knee surgery. And the junior goes, no, sir, I've been told not to do that. I don't know about this knee surgery. So there's a kind of imposed identity, and they fail then. And there's another battering, sort of battering from someone else that day. But eventually you start doing things that everybody agrees with and that they fit your role. And then you've exited out of, eventually you exit to this zone. So I think that's really useful, because it made us think about what are the implications for supervisors and what are the implications for the new practitioner themselves learning in the workplace. If your goal is to take on this identity, With me? So I'm going to talk about the supervisor first. There seems to be a role in, or we believe strongly, we always did, but it's reinforced our feelings about this, in supporting the new practitioner through that trajectory, helping them affirm their identity, helping them with that conflict resolution, and seeing that as positive about what's developing the identity, but coaching them to cope with it. And also a mentoring role, encouraging their participation in the interprofessional team, and almost being their advocate and their sponsor, making sure that they are encouraged to work in the interprofessional learning environment and do that well, to have their back a bit, but to push them out there a bit as well. And that's not to forget these other two important ones. Anyone else working with health, or probably other areas where things don't right matter, like engineering, education, there's a role of oversight, making sure everybody's safe, making sure that all the tasks get done and patient care is managed well. But for medicine and all health professions, education and career mentoring is important, because when you just graduate, it's only the start of the journey. Most of us, whatever our profession, nurse, radiographer, OT, specialise in some way. And in those first years of practice, you're working out where you're going to specialise, what sort of practitioner you're going to be. And they're very important decisions. So that leads us to think that there are 4 roles of a supervisor. So that's just a recap. Got this oversight role, I'll put that at the top now, that's probably the most important. This role coaching and role coaching in pastoral care, practice mentoring, sponsoring them within the workplace team, and the career and guidance mentoring. So it's no wonder workplace supervisors get tired, don't they? They do get tired. So what are the implications for the newbie? Well, that means they've got some clear responsibilities as an individual learner. They need to accept that they are on this process of developing their identity, and they need to be proactive. And importantly, they need to move from, in the kind of community of practice jargon, from being peripheral to really being involved. You can't keep circuiting the outside of what everybody's doing all the time. You can kind of do it for a while. I had a student once who was so nervous about fully engaging. She used to go and put one of those cassettes that you take x-rays under her arm and wander the hospital, so I didn't know where she was. And people would think she was doing meaningful, busy things, but she never did anything. She was literally peripherally circuiting the whole place all day long. So they have a mandate to actually share, participate, engage. And, you know, many of them do that very well, but some of them don't. Some of them feel overwhelmed and they don't. They particularly feel overwhelmed if they come from a different culture. Or if they're very shy, or they've got a short period of mental illness. We have 30 new doctors, 120 in total, over their first 2 or 3 years. Some of them are going to have, the statistics say a number of them are going to have depressive episodes during that period of time. So other things can stop them sharing, participating, and engaging. They need to do the paperwork and get it together. It's not just a chore for the junior, it's got other values around helping you reflect, helping you get organised. They need to actively contribute to their supervision, to the 3 monthly feedback, bring things, be really involved, and really use that as a learning tool. And they really need to go around and hassle to learn from others. You almost have to out there getting the stuff out of everybody else, because they'll give it to you and they'll love it. But you probably have to get out there and do things as well, and really be involved with all those groups that you're part of. And are these easy tasks? Of course they're easy tasks for us. They are part of our life, they're what they do all the time, but they don't appear to be easy tasks for all the really junior doctors or the late students who are on placement. For some of them, they're actually not that straightforward, and they're not what university really prepared them for. And I think it's because we kind of often have this kind of performance equation where we have a whole lot of competencies, and sometimes somebody mentioned accreditation boards. You know, you kind of think, well, you do all these competencies, and yeah, some of them can be generic, and then you've got a performance and all's good, but it's probably not. There's this bit in there as well. So that raises questions about the generation of the practitioner and how things change over their journey from undergraduate to new graduate to postgraduate. So I've got my little dog here to help me. His name's Harry, and we're going to start taking pictures. This one took a while, but we finally got it. Early on, this is probably a second or third year student in my world, he's on a 5 lead with really focused objectives and really clear outputs, as you can see. So he's performing very well at that stage and on his walk. And then eventually he's a bit freer, he's on an extended lead. This is probably his last 6 months before graduation as a health professional. He's wandering around, he thinks he's free, he thinks he's really happy, but the lead, I'm there. Keeping an eye on him. This would be, I couldn't get him to do this, but this would be his first week on the job. Yeah? Woo! I'm going to hope a house surgeon's like, oh, that's it. That's what I feel like. And there they go. After a while, they settle down and they're out exploring the world as a mixed breed team. This dog's called Irish. I don't know what she's doing. She's taken off. She's probably gone to general practice, or she's off somewhere she's not supposed to be. And then they come back, and you would hope, in our word, they meet with their supervisor regularly, and they start talking about their learning and what they're doing. And here's Isla, she's back on a short leave because she keeps wandering off. So I think that's the kind of things that happen, and that raises questions for me about the role of objectives and competency statements and how they're best used at each stage. And are they even relevant by the time people enter the world of practice, or are they better to be collating what they learned and discovering it along the way? And of course it raises issues. Are we coaching and assessing the right things when people are in the workplace? If these things here are actually those things, right, maybe we should be assessing how they engage, how they take opportunities, how they reflect on events, how they question, how they interact. Maybe they're the things they need feedback on. That raises more questions about what feedback assists them with their project management skills. What feedback and coaching helps them have a strong identity as a practitioner? What successful appointments? And how do we know they're ready to fly solo? So I think there are curriculum issues there across the whole of the longitudinal curriculum. So from being an undergraduate first year right through to being a specialist, and even more, which I call the longitudinal curriculum. And finally, for me, practice-based education is not just about preparing undergraduates for practice, but it is about that whole curriculum. And it is about what happens between the tertiary institute and the workplace, between the workplace and the professional education bodies, across all the workplaces. I mean, you can read those things. About the practice, the postgraduate and the undergraduate environment. It's about moving people through all those transitions in a career, which in medicine is 15 to 16 years. That's my last slide.